Good afternoon, everybody. So today we're going to talk about chamber quantification, assessment of LV function, and Doppler hemodynamics. And we're going to really dedicate the time to the left ventricle because that's sort of, first of all, because of time limits, and also because that's the function we do the most. And even today, on a daily basis, with our 100 plus echoes a day that we're doing in the lab, at least 2/3 of those are being ordered because the physicians want to know something about left ventricular function. So it's still our number one request for an echo. And therefore, it's something that we all need to learn to do well, because the truth is that it is not always done properly. And therefore, not uncommonly, there are issues with the accuracy of the results. And as any of you who is in our lab, you know we have all kinds of little tables and figures posted in the lab, and they all come from this document, which was the 2015 updated version of the recommendations from the American Society of Echocardiography for quantification, chamber quantification, LV volumes, and so on. Very well done document, and one of the strengths of the document is that it has a lot of very good tables that you can use for normal standards. That's one of the things that they really did well this last time. So when we look at left ventricular function, many of us first do sort of a subjective assessment of it. And as we do that, we learn to appreciate the percent shortening of the cavity that we're looking at in multiple views, as well as the percent shortening of multiple diameters as we go across, which is a function of circumferential shortening. And at the extremes, we do very well. No one will have an issue saying that this is an absolutely normal ejection fraction and a relatively normal size heart. And we all would agree this is a big heart. Whoops. This is a big heart that has a depressed ejection fraction. And our eye gets rapidly used to appreciating that there is a reduction in the shortening of fraction of that cavity as we see it as a whole cavity in the view that we're looking at. And of course, we integrate multiple views. And it doesn't take us too much of a training to even appreciate that this wall is not thickening, suggesting an old infarct is thin, not thickening, while this one is contracting. And of course, later on, we're going to have a whole talk on regional function. But from a global point of view, these two extremes are very easy to tell. One like this one is a little bit more complex. This is a normal size heart. It's not a dilated heart. And at this point in time, if we had one of these little audience response systems, and I ask everybody in the room to give an estimate of EF, I would not be surprised at all if we got something like this, which is what we got some years back in a course we were giving at the American College of Cardiology. And this was a case that we showed. And we can see that there were some members of the audience that said in the 20s, some in the 60s, and a wide spread between the 30s and the 50s. If you're the patient, you probably would have a little trouble with that level of spread when it comes to your heart. And what this shows you is looking at an audience of over 100 cardiologists in a room, all of them practicing cardiologists, they do echoes in their office, the problems that we have with this subjective technique. It can be done well, but it has to be done by experts. So a few tricks that I can share with you after 40 years of doing this. So, as I said earlier, yeah, you train your eyes to look at the fractional shortening of this cavities area, and we have 4 views here. Notice that this heart looks smaller in this view, suggesting some element of foreshortening. But overall, we look at that and say, okay, is that normal? Is that severely low? Is that middle ground? Where? So you kind of learn subjectively to appreciate that. You can help yourself a little by looking at the mitral valve. If the heart is a big heart, how much the valve opens and gets close to the septum can be a nice indicator, if we go to the previous case, you see that this valve opens and there's a big gap between the maximal opening and the septum compared to this one here. That works well when the heart is big. Beware of AI, because AI can do that the same thing. However, when the heart is small, like this one, you may have normal opening of the valve, and yet the EF may be depressed. So that's a sign that helps you when you have big hearts, not necessarily when you have normal hearts. The other thing that helps you is some very simple numbers, and we do them in the lab quite frequently. By the way, by quantitation techniques, this was about a 42%, so all of you can check yourself with what you thought it was. So the couple of things that we can do very quickly is look at the fractional shortening of the diameters and the fractional shortening of the area at level of the papillary muscles. And it turns out that if we do this quite often, on a daily basis in our report, and roughly about a 27% shortening fraction is equivalent to an EF in the low 50 range. Again, assuming no major wall motion abnormalities. You may have a base that contracts well and an apex that is aneurysmal. So this is in ventricles that are relatively symmetric, either diffusely bad or diffusely good. That measurement gives you an eyeball, an estimate of where the EF would stand. Likewise, if you do the shortening fraction of the area, a 45% shortening fraction equates to around 50%. Now, why is that? Because remember, neither one of these two measures are accounting for the long axis change, because the heart contracts and the long axis also shortens. This is only looking at circumferential function at the level of the base or the mid-papillary muscles. So it gives, but it helps you to get a sense. In this case, it was 25% diameter shortening fraction and 35% fractional area shortening, both of which go well with an EF in the 40s. Again, this is a heart that doesn't have any major regional wall motion changes. Now, the fractional shortening and diameters of the LV is very old. When I started doing echoes in 1971, 72 actually, already it was being measured by echocardiographers. So it was one of the very first measurements of LV function was in an end mode, looking at the diameters and fractional shortening. As time went by and 2D came on board, we realized that in many 2D views, the end mode measurement, if you were going to do an end mode, it would be this line here, is a tangential line. In fact, you can see it in this screen also. It is tangential. So these diameters are really bigger than the true diameters of the heart. And for that reason, current recommendations, unless you have the absolute magical, most excellent 2D echo in that day, they do recommend that these measurements be made directly from the 2D. And basically, for all the fellows here, since it's a measurement that we do every day, what you want to do is you want to establish a long axis of this heart. So this heart is a little bit tilted. So the apex is somewhere here. And this will be your long axis. This diameter has to then be perpendicular to that sort of imaginary long axis that you can draw. And then it's usually done just below the tips of the mitral valve. Now, sometimes I take some liberties because sometimes there's some heart that have that start small here and get much bigger in the middle because they're very distorted. And I tend to measure a little bit farther down. But the ASC recommendations is below the tips of the valve, at the base, and perpendicular to the long axis. And you measure the diameter in diastole and systole, as well as your wall thickness, to estimate left ventricular mass and hypertrophy, which of course our DGView program now does it pretty automatically. As long as the measurements are accurate, that's a good number to have. And this document has all the standards that we have them posted in the lab. I'm not going to spend time on them, but it gives you all the normal values for men and women for the diastolic, systolic diameter, and volumes as we get into volumes. And it gives you here, for example, what happens with guys and gals in terms of how they get bigger and the diameter. And notice that some really big guys can have end diastolic diameters of around 6. So we always have to account for the body size. And that's one thing that sometimes I notice the fellows, when they're reporting, they forget about accounting for the body size. That's very important because some really big people can have normal measurements up to 6. But we all know that the best way to assess global LV function is to have volumes, end-diastolic and systolic and EF. And of course, the ideal method, if you have a perfect quality imaging, is the biplane method of disc. Sometimes we do shortcuts and we only do a single plane. And the main reason for that is that the two-chamber view is a tough one to have perfectly done. Notice that both views in this beautiful example published in the document, the apex is pointing pretty much to the transducer. But that's not the case quite often, as I show you in a minute. The formula is very complicated because it's just taking the two long axes and normalizing them to each other, and then measuring volumes in each of the slides, and then stacking them together to add them up. And of course, manually, this would take you a day to do. The computer loves it and does it in a second. There's a backup method that the ASC actually does suggest when you have images that are not the very best. And if you do have a decent apical view that gives you a long axis, you can measure the long axis in diastole and systole and use the area at the level of the papillary muscles also in diastole and systole, and use an equation called the bullet formula because it's treating the LV like a bullet. Now, again, it's an estimate because if you have a lot of wall motion abnormalities, this is going to fall apart. So again, it's better for ventricles that are kind of homogeneous in its contraction, whether normal or abnormal. Very simple formula, 5/6 times the area and times the length. So it's a very, very simple calculator type formula that you could quickly do, particularly to get a ballpark figure of end-diastolic volume. So, show of hands. How many of you would say that this EF looks at least 50 or better? Show of hands. I would. I mean, if we apply the rules we just said, fractional shortening of the area, it looks like it should make at least a 50%, okay? What about now? Would anybody vote now that this EF is 50 or better? Hopefully not. So, look at the EKG. It's exactly the same heart. The only difference is a few seconds later, adjustment of transducer by the sonographer. So this is a beautiful example of foreshortening. Notice how smaller this heart is compared to here. So if you look at my arms, if the absolute movement of my arms is this, that's a bad EF, right? But now that same absolute movement, if I put it here, that's a great EF. So when you foreshorten, you make the cavity smaller, and you make the relative changes all be better. So ideally, because to this a tomographic technique, you want to cut through the center of the cavity, whether you're coming from a parasternal long axis, from a two-chamber, from a four-chamber. But at times we don't. So if you do this, you end up with that. Likewise, when you're in the apical views, you would like to really be coming through the center. But often we're coming tangentially, and we end up with a small four-chamber and a two-chamber that has an apex pointing to the side. That's your tip-off. Anytime you see the two-chamber with the apex out here, you know you're tangentially. Because in a perfect world, both should have the apex pointing pretty much into the transducer, which you saw on that beautiful picture from the publication of the ASE. And of course, that's not always possible. And that's why we often end up disregarding one of the two views and only doing single plane or using backups. If on top of that you have translation, which is very common in our post-op patients because the whole heart moves up with translation, then you may be perfect in diastole, but foreshortening systole. And we see a lot of that also. So those are issues that we have to learn to appreciate as a sonographer when you're doing the study, as a reader when we are interpreting the study. And the document puts several recommendations to try to improve on that from the point of view of respiration being quiet, imaging at minimum depth necessary, highest possible transducer frequency, and a bunch of things that should be an ABC bread and butter for every sonographer in our lab. The most important of all, of course, is to have access to the apex of the LV. And the thing we learned 30 years ago in a beautiful study where they did in the cath lab, they did the apical views and they had fluoroscopy. So they could see where the transducer was pointed to, and then they have the LV angiogram at the same time. And they showed very often that what we thought was the apex, because you feel the apex, was not the apex when the LV angiogram was done. Because what we feel when somebody is in the left lateral position is the distal end of the RV border, not the apex of the heart. And that's why we learned that we cannot put the transducer here. We have to put it sometime way down there, and that's where you need a little cut in the mattress to be able to do that. Of course, if you're in the ICU doing an echo, it becomes a little bit more tricky. So a lot of our portables are going to struggle more and have a little bit more trouble getting a proper apical view. So before any measurements are made, first step is to select the appropriate image that is less affected by foreshortening. And that is true for anything. That is true if you're doing LV dimensions, LV volumes, left atrial volumes, RV size. Any measurement we're making, the very first step is choose the best image, the best for that particular chamber. The preview option is great because you go through the entire study before you make a measurement. Don't start making measurements on your very first view. Go through the entire study. You might find the best parasternal long axis in page 4 because the sonographer went back and did it. So look at the whole preview before you measure anything. Left atrial volumes, LV dimensions, anything. Now, the multiple diameter method, which we published in the 80s, is an interesting backup because what it does is that it takes the shortening of the diameters, square them, and puts EF in the function of two components using the ellipsoidal geometric equation, which is the area length method. So if you look at an area length method done for LV angio or for 2D echo, it's a method that depends on saying the LV looks like a football and basically applying the geometry of a football to do 2D or to do volumes. If you use that formula and you play with it using 9th grade algebra, you can take the changes in volumes and the EF, break them down into dimensions, and express that as two components. Component A is this fractional shortening of the square of these diameters, and component B is 1 minus A times the shortening fraction of the long axis. Now, you can make 1 or 2 diameter measurements if you're in a hurry and do a quick down and dirty, or the method as it was published was basically averaging all of these diameters from long axis, parasternal long axis, for chamber to chamber. And in fact, it was a very good relation with EF by angiography and also EF by MOGA. We had close to 100 patients with nuclear studies, and both correlations were pretty decent. Big advantage of this method compared to the method of this is that you can bring in the parasternal long axis. And sometimes even with lousy quality echoes and for shortened apical views, we still get a decent parasternal long axis. So one of the advantages of this method is that it can bring into the methodology application of the parasternal long axis view. And sometimes we end up just using a couple of diameters from this view and maybe 1 or 2 from the other. So, trying to, and then this was published in 1981. And then 2 years later, we applied the same method to estimate volumes. And the thinking was very simple. If we look at the biggest diameter in any view, so you took all these 3 views, and whichever gave you the biggest diastolic diameter, you use that one. And likewise, the biggest long axis in either 4 or 2 chamber. Very simple. Your biggest diameter, your biggest long axis. We said, okay, if we multiply one times the other, that should relate to end diastolic volume. So we did in the cath lab volumes angiography using the calibrated stuff that you guys will never do anymore because nobody does it anymore. But in the old days, there was a very sophisticated way of calibrating the angiography and tracing the ventricles and doing all of this. So we ended up finding a very good relation, and this is nothing else but a regression equation. So this equation that many of you have used, it's just a statistical regression equation that compared the product of those two measurements with an end-diastolic volume. Now, if you have the end-diastolic volume and you have EF because you've got it with the method I just described, you can derive stroke volume and systolic volume with very simple formulas. And in fact, when we compare that in two groups, the initial series that was used to develop the method and a prospective series later, the relations were very decent for volumes. And this is, again, a backup that I use quite often when I'm trying to deal with trying to put together things and maybe not have the ideal quality of images for doing the method of disc. So, how big is this ventricle? What's the EF? Dr. Nabi, you're a level 3 training everything. Can you give me the EF and the end-diastolic volume in this patient?
Recommend cardiac MRI.
Recommend cardiac MRI. How much does a cardiac MRI cost?
It all depends.
It all depends. More than $100, right? Yeah. Okay. For $100, you can do this. All right. So this is an extreme case, but it shows you how contrast changed the game plan for all of us. So the same heart, just taking a little bit of, I can't remember if it was Optison or Definity, throwing it in, and this is what you get. Not only can you tell about the EF, which is pretty good, but look at the detail. There's a little bit of obstruction of the cavity right here. In fact, there is a tiny, tiny little cavity created at end systole, and maybe the tip of the apex not contracting that well. I mean, you get to details that you get likewise with MRI. So contrast can often rescue a study and save you some money on doing other studies. And now you could clearly stop anytime and trace and do all your measurements. And in fact, where we get the most bang for our bucks is with big hearts. Because this foreshortening problem can be really grotesque, like the case I showed you. But it can be more subtle, not quite as grotesque, where it becomes less appreciated. And in fact, if you look at all the studies comparing traditional 2D echo volumes with either CMR or CT, the tendency is for the 2D volumes to be smaller, for us to underestimate the size of the heart. So there are minor levels of foreshortening that even our eye cannot appreciate because they're not that prominent. And of course, they will be more noticeable in a big heart where you may have a volume of 300, but you ended up only calculating 190. So this is where contrast really helps, because you see, this is not a bad quality image. It was good enough that we could stop it and trace it. And we got an end-diastolic of 200 and EF of 35%. Whereas with contrast, it was a bigger heart and a smaller EF. And if this is someone you're trying to do a 2D echo to figure out need for AICD, well, that 35 versus 26 kind of becomes important, okay? And I'm not saying this because I'm a nice guy and I know a lot. I'm saying it because there's data, and this was published in 2001 by the Mayo Clinic group. They concentrated on bigger hearts, so you can see that in the scale, many of these are very big hearts, with EBCT as a standard. And the triangles are the measurements without contrast. There was a good correlation, but look at that, all the volumes are sub-estimated. Whereas when contrast was given, not only was it correlation, a decent correlation, but now it's almost in the line of identity. It's, you know, the broken line is the line of identity, and the regression line is not that far off. And you can see that when you do the Bland-Allman analysis. So contrast really helps to know better how big a heart is. And hearts are failing, hearts that are big already because of cardiomyopathy, mitral regurg, AI or whatever, that's when you get a lot of benefit in contrast. So again, for the sonographers, we know that you guys are never shy about using contrast. Continue not to be shy about using contrast. And in fact, the official recommendations are contrast agents should be used when needed to improve endocardial delineation when two or more contiguous LV endocardial segments are poorly visualized in apical views as per published guidelines. And in fact, our lab, under the leadership of Dr. Sugby, did a very study that was pivotal in making those recommendations. Over 600 patients, they all had poor quality images, and a report was given without contrast, and a report was given with contrast, and the attendings were asked, what would you do with this information without contrast? And what would be your next step? And then contrast information was given. And in fact, it was shown that there was a significant change in the EF in 17% of patients. New wall motion were picked up in 28%, and other studies were avoided, like just a minute ago when Dr. Shah was suggesting let's do a CMR. So, which in fact would be the appropriate suggestion. If even with contrast you cannot get a decent assessment, certainly today a simple CMR without any contrast is absolutely a perfect thing to do and very much indicated. Again, these are numbers that we have them in the lab, but this gives you all the males and female normal range, mildly, moderate, severely abnormal, for dimensions, for volumes, for EF. We still haven't changed our EF, and this is one thing that Dr. Naga here, I wonder whether we need to sit down and incorporate this, because we're still using a little bit different setup for what we call moderate and severe for EF. That's one thing that we may want to kind of discuss, whether it's time for us to maybe make a change in that. But we're not way off, but we are a little, right here in this area, we are a little bit in difference. And again, they have these nice figures that show you end-diastolic volumes getting bigger as people get bigger, both for males and females, and so on. Epical 2-chamber and epical 4-chamber and so on. And this is the EF, taking the EF itself. Basically, mild is 41 to 51. We use 45 to 49. Moderate is 30 to 40. We're using right now 35 to 39. We're saying moderate to severe in the low 30s, and we're seeing severe under 30. So, you know, we might want to readdress that and see whether we want to make any changes or not. And this is for biplane. So these are very nice figures that we have available to use. Now, backup. So a very good backup method, of course, is to compare your stroke volumes from your 2D measurements with the stroke volume with Doppler. In the absence of MR, AI is a very nice internal control. If one is 60 and the other one is 90, there's a problem. You don't see any MR or AI, and you're seeing a discrepancy that doesn't make sense. So for people training, for people learning, it's a very good internal control of using the pulse wave method, integrating the LV outflow diameter with the integral of the LV outflow velocity to get the stroke volume and cardiac output. Important tricks is, again, don't make the first measurement you see. Play that image. Play more than one frame, because you may get a very small LVOT in a given view. You open another view, it's a lot bigger, because it's most of the time a circular structure, and the same foreshortening problems that I just showed you earlier are going to apply to the LVOT. And we're going to talk about that a little bit more. Likewise, when you're doing the PW, you want to get close to the aortic valve so that you see the closing click. If you don't see any clicks, you're too far away. If you see both clicks, you're too much into the valve. So you inch your way until you see a good closing click, but not an opening click, because you want to put the position of the sample volume about the same place where you have done your diameter measurement. And back in 1984, when I used to have a mustache and be a lot younger, and Dr. Janet Lewis, which is professor of medicine in Washington, was a fellow, we published the cardiac output stroke volume method, both for the LVOT and on the same paper for the mitral annulus. And this was from the paper. These were the correlations that were obtained. Again, notice they're not perfect. There is some level of discrepancy between stroke volume by Doppler and thermal dilution. And this was using the mitral annulus method, and this using the LVOT. And of course, that opened the door to be able to do comparisons of one versus the other and calculate reggaeton volumes in AI and MR and so on. Today, we're doing CT a lot, particularly with the TAVR program. And the CT has made us a little bit more humble, because through the years, we always knew that the mitral annulus was not circular, but we had no other choice. So for the mitral annulus, we have applied a circular geometry, knowing very well that it was a stretch, because the mitral annulus ain't circular. With the LV outflow, where we say, well, that probably is not too far off. Probably it is circular most of the time. And in fact, it is circular 2/3 of the time. But what we're finding with CT, when we're looking at TAVR patients, is that not always it is circular. It's often oval, which means one diameter is a lot smaller than the other. And if this is the one that you are measuring in your 2D, guess what's going to happen when you apply the circular formula to get an area? And I think this is a very important discovery because it explains why we get cases where the stroke volume looks low and the heart looks great when you look at the 2D echo. And it may explain some of those low gradients, low volume, normal EF, AS patients that the literature is full of discussion about it. Many of them are just garbage, bad data. Simple as that, okay? So this is my advice. LVOT area will be underestimated if we have this type of geometry. We don't know about it. So beware of too small LVOTs. In an adult, unless the patient is a penguin, you should not have an LVOT diameter under 1.7. I still see people measuring 1.3, 1.2, 1.4 for LVOT diameters. Maybe if you're 3 years old, you have that, okay? So beware of any LVOT diameter under 1.8. You have to really look hard, look at multiple views, or not even use it. 1.7 maybe if you look at the body size and it's like 4.8, 90 pounds. But beware. You don't have 200-pound people with diameter of 1.7, which we frequently see in the lab. It doesn't happen. It's false data, which means you're going to end up with low stroke volumes, low cardiac outputs, and if it's an AS patient, maybe a critical valve when the velocity is only 3. So it's a very important source of trouble. All right. So moving on, we could do 3D, and we are doing more and more 3D these days. The methods are becoming a lot easier, a lot more semi-automatic. So you just get some decent images, you apply a few little tricks, and lo and behold, you end up with something like that. You pick up the apex and the 2 points of the annuli, and bingo. The computer takes care of, traces the chambers, give you beautiful information, and give you numbers. And that study, 158, stroke volume 95, EF 60%. Great. Hey, if that agrees with your eye, take it to the bank, report it. And in fact, this was a pivotal study because it was a multi-center study where they compared this method with CMR. And results were pretty decent, as you can see here, for end-diastolic volumes by 3D, end-systolic, EF. But notice that there is still that tendency. When CMR was around 300, 3D to D was about 230. It would be great if we could give contrast and do 3D. If that day comes, 3D is going to be dynamite. But it still hasn't come. Because when you put contrast, the systems cannot do a good job in tracking those borders. And it goes to hell. If someone can conquer that, and we can do contrast, and then have the computer do a 3D for us, we'll have fantastic data. Because the same problem happens. We're still foreshortening. Now, in that study, 2 things. You need decent images. But the other thing is, they did find that frequently with 2D echo, we tended to trace through the, bringing the trabecula, call this the border. So if you ignore that and you trace out here, you get closer to the CMR. So actually, that has taught us now, and now when we do even plane 2Ds, you notice that we are now trying to overtrace closer out because the lesson we learned with this. Now, when you put contrast, it takes care of it because the contrast covers the whole cavity, and you just trace the border. So that's the other beauty of the contrast, is that it goes in and takes all that trabecula in, and you just trace the border. So even with 3D, we still have issues with the underestimation of volumes. And the limitations of 3D that we still are struggling with is that you still need very good quality images. Inaccurate results may be incorrectly accepted. This is a problem if you're in the street and people believe the 3D, they will report that data and maybe it's totally wrong if it's not properly done. And therefore, the big question we all wrestle every day, how do we report a study with a normal EF by eyeball or 2D measurements who appears abnormal by EF? Or the opposite. It looks abnormal to us, but the EF, the 3D is giving us a normal. You know, when you have that discrepancy, who do you believe? Today, I still go with my eye and my simple measurements by 2D. I'm not ready yet to blindly accept a 3D value if it doesn't agree with everything else that I have learned over 40 years. That's a decision everybody will have to make when you go out and practice. Because 3D here is being used more and more, and it would be great if we could integrate it with contrast. And of course, now we have speckle tracking. We're going to talk more about this, I think in December, when we had the talk about regional function, we'll bring this back. We today are talking mostly of global. And of course, strain is a fantastic technique. I love it. It's beautiful. Dr. Naga loves it. He's published on it. And it has a lot of wonderful things. I started my career with ENMO trying to look at myocardial function, doing stuff that took me a day for one patient. And this does it in a microsecond. So, so here what we're seeing, of course, is speckles moving and tracking either longitudinal vectors, radial vectors, or circumferential vectors. So you can do circumferential, you can do radial, you can do longitudinal. Today, for global function, we are tending to rely a lot more on the longitudinal, which is the one that we're seeing almost in every case in the lab, if the images are reasonable in quality. And you get these beautiful curves from multiple regions, and then an average of all that as the single averaging for the whole thing. And of course, if you have a lousy heart like this one, it really brings it out because you see it, whoa, this heart sucks. And you see also the differences. You can see that even though this is a cardiomyopathy, there's a lot of regional differences. There's an area here that's virtually akinetic. There's a segment that is a little dyskinetic, and then you have these other ones that are hypokinetic. So it quickly brings in the heterogeneity of contraction, even in a non-ischemic cardiomyopathy. And of course, then you get the bullseye with all the measurements of longitudinal strain and integration of all the values into what we call an average, which in this case was 21%. Normal is better than minus 18, more negative than minus 18, but with a little caveat. And the caveat is that not all machines give you the same value. So some machines, you may have to drop it down to minus 17. Some people are arguing maybe minus 16. There's a new Philips now that I'm seeing a lot of 16%, when in other machine, the same patient have had a 20 because the patient was done twice. So we're still struggling a little bit as to what is the magic border of normality in a GE, in a Philips, in a new Philips, and now we have a bunch of Toshibas, we have a bunch of machines. So that's one of the things that we still have to kind of define. And then we have this other issue, very interesting issue. This is fascinating from a research point of view, right? Here you have a heart that is cavity obliteration, EF is 90%. It's a classic end-stage renal with a severe LVH and hypertension. No one would argue that the EF is hyperdynamic in every single view, almost cavity obliteration. So from that point of view, the patient has a wonderful high EF. But it has a global strain of minus 14 with many areas that are abnormal, and you see the curves. So here we have now an important strength of this technique, picking up subclinical abnormalities. And that's where the impact of this could be, okay? In addition, it could have an impact for regional function. We'll talk about that in December. But in global, from a global point of view, it gives you the opportunity to discover subclinical global dysfunction in hearts that to the eye are looking okay. I don't see anything horrible. And of course, that has been used in the chemotherapy world with the cardiotoxicity business, trying to say, okay, we can detect early signs of dropping of myocardial function when the EF is still okay. See, by the time it went to 49, some might argue it's a little bit too late. You might want to initiate heart failure therapy at this stage. Again, work in progress. This still has to be proven by clinical trials. But it's a very interesting concept. It's the ability to detect subclinical changes before the global EF drops. But it needs very good quality. And again, we cannot make it better by using contrast. Same problem as 3D. So whichever company can really conquer that issue, they're going to really take off, because once you give contrast, you can't. You cannot do strain. You cannot do 3D volumes. You cannot do strain. So you need really good quality images. The other thing is, if you have inaccurate, you don't know how to, is it bad? If I get a global strain of 15%, minus 15, and my eye says everything normal, do I buy it? Do I look at the image quality? What do I do with that number when I'm not sure what to do with it? So how does one know that an abnormal result in an individual is really a really abnormal result? We talked about this already. There's some issue with reproducibility. It's getting better. Particularly if you're doing research, like Sharif has a core lab doing this, his reproducibility gets better because now you have a lot of closed techniques to do it well. We still have to work on this. Strain is basically the shortening fraction of segments throughout the heart. And we know that this is going to be load dependent, and there still needs a little bit of more work to know what are the impact of loading conditions on strain. But the most important thing is, what do we do with the data? How do we treat a patient, other than some guy in chemotherapy? How do we treat a patient that is just coming by for whatever, and we have a minus 15% or 14% strain, and yet everything looks okay by global findings, 3DF, whatever. How do we treat that? What do we do for that patient? And it's not my opinion. If you look at here now, this was as of September of this year, over 1,600 publications in PubMed on strain. And yet, no one has ever yet said that we can make an important clinical decision for treating a patient based on these numbers. Perhaps the chemotherapy might be the first one to maybe have something to say. So we're still struggling. It's not necessarily that it's a bad technique. It's a wonderful technique. I love it. But it's just so sophisticated. It gives you such degree of subclinical abnormality that we don't know what to do with it. What do we tell the patient? And what do we do medication-wise differently if you have an abnormal value in what everything else looks okay? So I think that smart people like Dr. Naga and others in the future are going to have to help us deal with this, because we don't have a good answer for that. All right, so let's spend the last 15 minutes talking about hemodynamics. Again, this is something we all do in the lab, but it's good to refresh a few things. I already showed you this slide, which was our first publication back in '84, publishing the cardiac output method from the LV outflow and the mitral annulus. And of course, that opened the door to be able to compare one with the other. And subsequently, 2 years later, we were publishing our method for regurgitant volumes, regurgitant fractions in patients with mitral regurg or AI. So let's talk a little bit about feeding pressures, and I'm going to only spend 2 minutes here because our esteemed Dr. Naga will do a whole session on this. So this is basically, think of this as an intro to what his talk will be. And when we talk about feeding pressure, the most important thing is to remember there's a lot of things we call feeding pressure. So it's kind of like a universal term that means a lot of things. Your mean left atrial pressure, or your mean PCW, which normally is less than 12. Your end-diastolic pressure, which normally is less than 15. Or the pre-A pressure, which is usually less than 12. And if you're in the cath lab doing only left heart cath because you cannot justify a right heart cath and therefore you will not be paid, the pre-A wave is your closest estimate of your mean LAP. So in the cath lab, it's a very good idea to train yourself to report 3 numbers: systolic, pre-A, EDP. Because if your report is 120 over 8/10, that's normal. If it's 120 over 20/22, that's very abnormal. That guy's sick. If it's 120 over 10/22, you know that it is a patient that has and diastolic elevation of pressures, which in itself is an abnormality, but still is keeping the LAPs normal. If you don't give those three numbers, if you only give 120/22, you have no idea what's going on with the LAP. So get yourself in the cath lab in the habit of reporting all three of them: systolic, pre-A, EDP. Because that's the only way you can tell people what the LAP is likely to be, because they are actually pretty close. And this is the update of the recommendations. Dr. Naga is going to give a whole talk on this. And basically, simple concepts that we go from normal to impaired relaxation to two types of elevations of feeling pressures, one where you have a lot of restrictive feeling with a big V wave, and one where everything gets pulled up. And they have their own patterns of transmittal velocity, changes in the E prime, and left atrial pressure. And I don't want to steal the thunder from Dr. Naga, so he'll spend more time on that. But as you know from spending every day in the lab, this is something we report almost in every study unless we feel we can, and then we have a statement unable to assess diastolic function. So you are able to now give global numbers for EF function. You can give some estimates of feeling pressures, and often we can do estimates of PA pressure, and that's simply based on the fact that the 4V square equation, which is a simplification of a big, long Bernoulli equation, that equation tells us the pressure drop, the pressure gradient between two chambers when there is a discrete stenosis, a membrane, not a tunnel. So if you have a membrane, something creating a discrete stenosis in a biological system of the heart, the gradient drop, the pressure drop between those two chambers can be estimated with 4V squared. And of course, a regurgitant valve becomes a discrete membrane. A stenotic valve becomes a discrete membrane. So you have discrete stenosis when you have stenotic valves, and you have discrete stenoses in a regurgitant valve. So being able to measure those velocities then allows you to estimate the pressure difference between the RV systolic and the RA, which is what we do every day when we take the peak velocity of the TR. And the important thing here is multiple views, because remember, Doppler needs as parallel as possible to the sound being to give you your best measurements of velocities. So for TR, you use everything. You use your RV inflow view, you use your short axis views, you use your apical forward, apical to subcostal, wherever you can, and you go for your highest velocity in any one of those views, because that's the likely one to be more parallel to the ultrasound beam. And then that peak velocity, applying 4V squared, gives you this gradient. Now you need to estimate the RA pressure to get absolute measurements of RV systolic. So we are not doing PA systolic, we're doing RV systolic. In the absence of pulmonary stenosis, it's the same. But beware of that, because sometimes I see you guys doing a report for PA systolic pressure when you have a stenotic pulmonic valve. In that situation, you have to change it to RV systolic pressure. And in fact, you can give PA systolic pressure, because then you can subtract the gradient of the pulmonic valve to your RV systolic. So you can give them all. You can give the PA systolic, you can give your RV systolic, because you calculate the RV systolic, and then you subtract that gradient that you see from your pulmonic valve. And you can get them all. But beware of that. So in the absence of PS, which 99.9% of patients do have, then we change the term to say estimated PA systolic pressure. And don't forget that if you have a very nice quality PR tracing, which we don't always get, but if you get a beautiful one, you can also estimate PA diastolic pressure. Same concept. You take this 2 meters per second, 4V squared will be 16, so your PA diastolic is going to be 16 plus whatever we estimate RA to be. Very similar concept. Problem here is that often we don't get good, nice quality tracings, PR tracings. And this is a case that we got everything. So you see a patient that has a heart failure with a low EF, 3.2 velocity, so that gives you a gradient of 41. Now we need to add the RAP. in which case in this patient had poor collapse and had this type of velocities. We're going to show you that later. So we go into in 15 to 20, so we end up with 56 to 61. PA diastolic, same thing, 2 meters, so 16 plus, and we end up with the same thing, PA diastolic of 31 to 36. This is one area that I'm in a little bit of disagreement with the most recent AFC recommendations, because they are proposing a number. And I don't think that we're always that good to give a number. I mean, half of the time, I feel comfortable using 5 or using 10, maybe 2/3 of the time. But there's at least a 40% of times that I don't feel comfortable saying that this is 7, 5, 12, 15. I think the range is more honest. So personally, I'm going to stick with giving a range. I'm not sure what you think, but I feel a lot more comfortable in many cases giving that range, rather than to fix myself to a number that you can always be sure. And these are some of the recommendations, are basically integrating the size of the IVC and the collapse with the hepatic veins. One caveat, the hepatic veins work only if you have sinus rhythm and you're not a transplant. If you're a transplant, or you have atrial fib, or pacemaker rhythm, or junctional rhythm, in other words, if you do not have effective atrial contraction, then this has a big X. It's of no value. Okay? Because when you are in atrial fib, 90% of people in atrial fib will lose the S velocity anyway. So they all are going to look like high RAP. So in atrial fib, in transplant patients, in pacemakers and things like that, we really end up only being able to apply IVC size and degree of collapse, unfortunately. Patient has a nice sinus rhythm, yes, we can bring all of this together, and they can be very helpful to give you an estimate. The bigger the IVC, the less the collapse, and the more absence, the smaller the S, and the bigger the D, all these things are helpful. And this is, these tables are available from the AC recommendations. There's nothing wrong with putting them in the lab for review. So when you have the ability to do this, of course, we can do a lot of things clinically. This is the beauty of these techniques, is that they truly change our practice of medicine. Because now we can often, most of the time, distinguish whether somebody has no heart failure at all, or they have heart failure with low EF, or heart failure with preserved EF. It's seldom that we struggle not being able to make that distinction. We can determine EF in multiple heart conditions, CAD, valvular disease, and use that in a clinical management of patients. We can assess, we can also use that to prognosticate, make decisions about ICDs and so on. And we can also assess the hemodynamic response to therapy. Very important. I think when people come back with repeated admissions of heart failure and they get an echo, EF is the least needed information. Because how often do we see a dramatic change in EF from admission 2 to admission 5 in a patient? What we can see, and we have lots of examples in our teaching files, are drastic changes in filling pressures and PA pressures and cardiac output. So if we're going to do an echo in a patient coming back with a heart failure, let's do it for hemodynamics more than EF, because EF seldom changes. And of course, this is very important. There's a big difference on how we treat somebody who has an EF of 20%, very low stroke volume and cardiac output, from one that has an EF of 20%, but a decent stroke volume and cardiac output. From the point of view of diuretics, how much diuretics we can use, and so on. One patient may need dobutamine, may need an LVAD, may need a balloon. The other one just needs Lasix. But if you give Lasix to the guy that has stroke volume of 20 with a wedge of 25, you're not going to do well. The patient is going to trash. So just simple information of putting together the global function, the stroke volume, and the filling pressures and PA pressures is extremely helpful on our day-to-day management. And of course, we can use these measurements to assess valvular lesions, as we will see in previous talks. To do this, we need to know what we're doing. We need to have good 2D and Doppler data. If not, garbage in, garbage out. For flow measurements, the pulse wave Doppler has to be placed in correct places. Mitral annulus, LV outflow place, this has to be very well defined. It's not like I feel like I put it there and move on. You really have to know what you're doing when you place these sample volumes. For the LVOT, close and click. For the mitral annulus, it's important to see the image in motion, see the valve opening and closing, and put that sample volume right at the base of that valve opening and closing. And notice that the annulus moves. So you have to pay attention to that, because otherwise in diastole, you may have placed it correctly, but in diastole, the heart may move out of that place. So you have to place it in the right place in diastole, because that's where you're going to integrate the velocity. So all these things require attention when you're doing the study. Gains have to be correct, and of course, the switch speed should be at 100 for proper measurements. CW has to be parallel to flow for pressure gradients, and we need to have expertise that you all are gaining by spending time in the lab. And we should only measure when we feel strongly about accuracy. Please do not say inadequate TR, inadequate TR velocity, PA systolic pressure is at least 22. What have you told the doctor with that? What is the clinician taking care of the patient going to do with that data? You're telling him, I have a trashy data, and yeah, the patient is at least alive. I mean, the PA is at least normal. Is that helping me any? So that sentence was placed in the report to be used only in one instance. If you have a lousy jet, and despite having a lousy jet, you still get a PA systolic of 50, then you say, yeah, it's important because you're saying, it's not a very good jet, but it's at least 50, which is bad. Okay, it's like saying, I'm not sure what the EF is, but I can tell you it's at least less than 40. Okay, that's giving me some help as a clinician. Okay, but if you're telling me it's a lousy heart, I mean, it's a lousy view, I don't know anything, I cannot see anything, but the EF is at least normal. Yeah, really? So that statement should only be used, it was placed in the computer just to be used for that. And I see you guys using it all the time with it's at least 25, at least 30. Think of the doctor reading the report. What are they going to do with that statement? All they can do is say, these guys are out to lunch. Okay? So it's only a good statement if the at least is high, because then you're helping. Now you're telling the guy, yeah, this guy has PA hypertension. I'm not sure how bad, but it's at least that bad. Okay? All right. Thank you very much. We're right on time, but we can take a couple of minutes for questions. Questions, comments, jokes?